to, another person joining. One second here. We'll do the introduction as soon as we get everybody in the room. All right, as they're joining, I'm Brett Klein with Eisenhower Health in our marketing and community education area of the business. And thank you all for being here, both in person and online via Zoom. And for those, just a few housekeeping, as those here in the building, we have restrooms out in the hallway as you came in. We have a handicapped on the right. We have men's and women's on the left. You can't miss those. And then water fountain in the hallway. We have gone sustainable here on campus. So for our 5,000 employees, we do not have plastic water bottles anymore. We have lots of water fountains and things like that, but we're trying to get rid of all the plastic out here in the desert. So that's a new sustainable course of action for the hospital. And then today's presentation, Sacroiliac joint pain with Dr. Shah, and he's going to give you a background of where he's coming from, which is much cooler, as that we were just talking about, than here. But he's been with us a while, and he'll tell us more about this, and then we will open up for Q&A at the end. And for those who are online, please use the chat feature to ask any questions, and then we can also open up at the end for Q&A. With that, Dr. Shah, I will leave it to you and get going.
Thank you so much, Brett. Appreciate it. Welcome, everybody. Thank you for spending your late afternoon on Tuesday with us. I really appreciate it. My name is Tejas Shah. I'm a new interventional pain doctor here at Eisenhower Medical Center. I'm with Desert Orthopedic Center, and you might have maybe heard about my colleagues, Dr. Kassam, Dr. Wong, and Dr. Patel. But we are in the orthopedic group with all the other hand surgeons, spine surgeons. So it's good to be here with all of you. And we'll get started. We're going to talk about a topic not many people know about, a diagnosis that's not really well known, not only with just regular patients, but even in the medical community. A lot of doctors, for example, don't even really know much about SI joint pain. So I wanted to spend some time going over it, and we'll take a few tangents. We'll talk about some other stuff along the way, but we'll have a good, hopefully, an upcoming hour for you, and then we'll open up to the Q&A at the end, so you guys can ask me all kinds of questions. I don't want you to be shy. I do want this to be more interactive, so we'll definitely get to all those questions at the end. So we'll get started. All right, and thank you again for being here. So this was working before. I guess it's not working anymore. All right, I'll just click it. So first, I just wanted to give you a little background about me. I'm a new interventional pain doctor, so I just actually did my training last year. I was in the, most of you probably have heard of this city, New Orleans, Louisiana. I was doing my fellowship over there at the Louisiana State University Medical Center. We spent time at the VA, we were at the University Healthcare Center, and then we also spent time with a similar hospital, Eisenhower Healthcare, it's called Ochsner Medical Center. Some of you guys might have been treated there before. And then that was my subspecialty, my fellowship. And so my training was in physiatry or physical medicine and rehab. That's also a field not many people know much about. And that was actually in the city of Philadelphia, Pennsylvania. And I did that at the University of Pennsylvania. And while I was there, they actually just opened up a new part of their hospital. So it was an exciting time to be there. I am actually from San Diego, California, so that's why I'm down here. I always wanted to go back to Southern California, so I'm glad I was able to find a job sort of close to home. My training, though, has been all over the place. I didn't mention it here, but I did my medical school in Michigan at a school, not University of Michigan, but a school called Oakland University. So I think if you look at my CV, nobody will be able to figure out really where I'm from, just because I'm all over the map. The Northwest, I haven't tackled that yet. So I know we have a lot of snowbirds from the state of Washington and Idaho and Montana. So I'll probably just have to visit that. But who knows, maybe I'll do some kind of training there in the future. Yeah, no, you're right. But yeah, California has some great hikes here as well. So I definitely have to find an excuse to get up there. All right. So part of my interest, so one was hiking, as you mentioned. I also do love sports. So unfortunately, it's probably been bad for me in terms of like how the stress rooting for my sports teams. My sports teams are not very good, but it's built a lot of character. So I do think it's made me, build character along the way. And I do love traveling as well, something I've been able to do more so in the later years of my life. So more than happy to, I think I was just talking with a gentleman about like Germany and Austria earlier today. So love hearing about places to go to. So that's a little background about me. All right, so let's get talking about SI joint pain. First, the question, what is SI joint pain? Well, first we have to identify the structure of what the sacroiliac joint is, right? That's just like medical jargon, doesn't really make sense. So right here, where my mouse is this is your ilium, the colored part. And this bone is sort of half of your pelvis. But this ilium right here, this part specifically, it joins with the sacrum. And it's hard to make out here, but it forms this little joint here. It's a very like variant joint. It's like a river or a snake, and it kind of overlaps. But this is a big joint in our body. And so this is what the sacroiliac joint is. And as you can see on the right side is bounded by sort of ligaments, and it's the lower part of your spine. So your lumbar spine is sort of here. You can see it out here. And then this is part of your spine right here, your sacrum. And you have your sacral nerves exiting. So a lot of you guys I know have had x-rays and your MRIs taken. And you'll hear things like your S1 nerve or your S1, S2 foramen and all that. That's what they're kind of referring to. And then this little guy right here is coccyx. Not known about until someone has pain there, but that's also a part of your spine. So our spine is actually split into four different segments. First is the cervical spine, which is your neck. Then you have your thoracic spine, which is basically between your neck and your lower back. It's kind of the area where your lungs are at. And then below that is your lumbar spine. And below that is your sacrum spine and your coccyx. So as you can see, there's different segments to the spine, but our focus is going to be on your SI joint pain. And you can kind of see how the ilium right here kind of overlaps a little bit. So it's kind of really in there. It's kind of squished in between. But because of how the joint looks like, it can give a varied pain presentation. And so we're going to talk about that in the future in a minute or two. Like I said, SI connects your spine. Now, what's the function of your sacrum spine? Your spine has different functions depending on where you're at. For example, your neck, the goal for your neck is to rotate, right? And so it's not really focused on taking off the load of your body, but your lower back is. And so your sacrum, the goal is to support the weight of your upper body and to really absorb those shocks as you kind of get older, especially as you start losing the wear and tear of your discs, you start having problems with that. And that's because it's not able to do the job that it was meant for. And so the main function is to absorb the shock. So when you're able to twist and turn and play those games when you're younger or do your household chores, like when you're putting away your dishes and you got to kind of bend down and you're twisting your spine, all that. We don't realize it, but you're using your facet joints, which are part of your spine, and your disc, and they're kind of working in tandem together. As you get older, sometimes those things get disrupted, or if you get like in a car accident or you have a fall. And so when that happens, that's when, unfortunately, you have pain. The last bullet point, we talk about degrees of rotation. So I want your neck to be able to rotate really good, and I want your lower back to be able to rotate. But your SI joint, I don't want it to rotate because your SI joint is tied to your hips on the side. And so it has very, very little degree of rotation. And translation just meaning it's going forward and backward. So it's much more limited than the lumbar spine. And that's going to be really important as we talk about some of the treatments later on. But just know that less movement of the sacrum, the better it is for you. Some of the background. So as you guys know, low back pain is very prevalent. Up to 85% of the chief complaints in our healthcare system is from just low back pain. And up to 15 to 30%, depending on what paper you read, of pain that does not radiate. That's what we call non-radicular, if you've heard that before. That is about 15 to 30% of that is SI joint pain. And it does unfortunately, it gets missed a lot. One of the reasons why it gets missed is because it has a different sort of population, right? You have the older population that have the wear and tear that present with the SI joint pain, but it's also prevalent in a younger population, especially women of weight-bearing age. When we're pregnant, all kinds of changes happen in our body. We're going to talk about that in just a minute, but just to kind of give you a preview, your pelvis sort of gets wider, your hormones lax your ligaments, and now we start losing that firmness that the sacrum likes to have, that SI joint likes to have. And that can, unfortunately, cause pain for women of weight-bearing age, as well as kids that are, playing sports, right? They're constantly wear and tear. And if they're not stretching correctly, if they're not taking advantage of the stretching program that they have, and they're, overusing their muscles and their ligaments, they can also be prone to an SI joint pain. So it's one of those rare things, right? If I see a 23-year-old, I'm not going to have arthritis as the top of my differential. But if I do see pain in that area, then I will probably think about SI joint pain. And SI joint pain is also part of like autoimmune conditions. So some of you guys know the rheumatologists that we have here. They treat a lot of our autoimmune conditions like ankylosing spondylitis, fibromyalgia is considered an autoimmune condition. We're finding more and more information about that. So SI joint can also be kind of tied into that. And that's something we have to just be mindful for as well. Now, one thing, I think the theme that I've kind of talked about here is motion, right, of the SI joint. Well, when we fuse your lumbar spine, that a lot of surgeons will do because you have sciatica or you have pain that's been going on for a long time, it's going to cause your lumbar spine to be kind of fused, and it's going to restrict some of the motion. Well, that motion, unfortunately, will get passed on to your SI joint. And so a lot of people that have back fusion, of course, you want to do that to take care of the pain that they have at the time. But unfortunately, it can lead to what we call segmental disease. Means basically the floors above and the floors below. The floors below, meaning the SI joint, tend to get affected. And so that's also one of the risks of getting SI joint pain. So this is a sort of a little background on the epidemiology of it. I always call this like the great deceiver, And so right here are 3 pictures, okay? We're not really talking about the picture on the left or the right, but I know you guys have heard of that term. We're talking about in the middle. But let's talk about on the right. I hear sciatica all the time. So sciatica is a term just for any pain that goes down the legs, right? I don't like that term too much. The sciatic nerve is actually one of your peripheral nerves that you have, and it kind of presents itself maybe at the top or the middle part of your hamstrings. And it's a peripheral nerve that gets essentially branches from your lumbar and sacral nerves. You can kind of see it forming there. And people just say sciatica, but what it really refers to is you probably have a pinched nerve in your lower back, your L5 or your S1. So like radiculopathy, that's really more of an exact statement. But before I have any MRIs showcasing that you have a pinched nerve, we just call it sciatica. But you can see the distribution of it going down the back of the leg. It's supposed to sort of light up in red, right? And then I want you to go on the far left. You see facet mediated. What does that mean? Well, part of your lumbar spine, the back part of it, not the front part, the back part of it, those blocks, those vertebrae that we call the Lego blocks, they're connected to each other by these things called facet joints. And you have a set of them at each joint, at each sort of level. And that can get arthritic over time as well. But you don't just have the pain in the back. All this colors you see, the blue, orange, green, that refers to what your facet pain could refer to. Referring meaning, even though you have arthritis there, your pain could be elsewhere, And so I have a lot of people that come to me and that tell me I have L4, L5 facet pain. And I'm like, oh, great, you did my job for me, But what I look for is where your pain is at, right? I always, and I'm going to say this multiple times, okay, I always treat the patient, not the imaging, right? I look at imaging is important, but I don't just treat the imaging. If I treated the imaging, then almost every patient over 50 would probably get some kind of surgery because everybody has, arthritic changes in the spine, and that's okay. It's wear and tear, right? I just got my Tesla checked at the tire shop, and apparently I'm losing tread on the tires, and I need to get like a tire replacement. And I just bought the Tesla like in August. I'm like, how is that possible? I just bought it. But, we don't treat anything until you start having symptoms of it. And I did have symptoms of my tire. That's why I brought it in. I had a screw in one of my tires, so I had to get it fixed. So now we've talked about the sciatica. We've talked about the facet-mediated pain. Now look at the SI joint pain, right? Can you guys kind of see the overlap there? You see the overlap between sciatica and facet-mediated, and then the SI joint pain? And don't forget for the SI joint pain to look at your lateral part of your calf, the outside of your calf and your foot. You can get SI joint pain all the way there too. So that's why, as an interventional spine doctor or a spine surgeon, this is a very hard diagnosis to make, right? It's a clinical diagnosis. I don't just go by what your imaging says or even what your symptoms are, right? I have to rule out these things. And sometimes, actually, more often than not, you probably got at least 2 out of 3 or all 3. And so we got to figure out which is the primary generator and then kind of go after that, okay? So SI joint pain can mimic several lumbar spine pathologies, but it can also be additional to several lumbar spine pathologies. And that's like an important takeaway from this slide. What causes SI joint pain, right? I wish I knew the answer to that every time someone asks me. Most commonly, it's going to be arthritis, right? Over time, as you start losing the discs in your lumbar spine, you're going to get arthritic changes. Like, what is arthritis? Arthritis is just wear and tear. When you start losing that space that you're born with, that you have in your teenage years, right? Whether it's in your knees, whether it's in your fingers, whether it's in your hips, whether it's in your spine, you start getting bones closer to one another, right? And I always hear that term, bone on bone. What does that mean? That just means that you've lost cartilage, you've lost disc height, that bone comes close to each other, and it doesn't like to be close to each other. That's when it kind of creates this inflammatory reaction. Now, I can't go through each step of that. That's probably outside the scope of this lecture. But when that happens, that can cause pain. But it doesn't always happen to everybody, right? Because your body adapts to it. Our bodies are kind of amazing in how they adapt to little small changes, right? I mentioned ago, I don't treat the imaging, I treat the patient. I see all kinds of imaging sometimes, and I don't treat it because patients don't necessarily have pain there. So I only treat where there's pain, and I can correlate that to the imaging that I find. Another is injury or trauma, right? That's pretty straightforward. Anytime you have trauma, or whether it's a car accident, it's a fall, you kind of upset the balance that's in place there. And that's when you can get your SI joint to become hot. That's one of the terms we use, meaning it's getting inflamed. Pregnancy, weight gain, we covered that, I think, a couple slides before that. And then, biomechanical issues. This refers to the prior lumbar surgery. I talked about that. Some people have leg length discrepancies. Again, that might not matter to you when you're younger, but as you get older, whatever changes that you're supposed to take naturally, you might kind of hit a barrier with as you get older, right? The arthritis might affect you differently. Some people have scoliosis, which is a curvature of the spine. Depending on how scoliotic you are, meaning how curved you are, you may have to see a surgeon, but more often than not, those cases are just kind of absorbed. Now, if you have scoliosis and you get arthritis, right, that's going to cause more changes. And so that can, unfortunately, lead to SI joint pain also becoming kind of hot or becoming active as well. But we just kind of monitor as you age. So those are things that can predispose you, but does not always mean that you're going to get SI joint pain from that. Finally, overuse, right? You can see this mostly in the younger population. That's not maybe tending, that's probably overdoing it when it comes to their activities. And so that's one of the other reasons you can get SI joint pain as well. So these are all the different causes. Again, and although it's important for me to identify that, I obviously do my best as I can. It doesn't matter that we identify it, right? It's important because then we can obviously treat the underlying issue. Sometimes if you have a leg-length discrepancy, if you have something, then you can kind of treat that, and then it will prevent you from getting worse SI joint pain. But my goal is to treat the pain first, right? So as long as we treat it, you can still have all those things, right? You can still be pregnant. You can, still maybe have the weight gain, right? You can still have this dealing with inflammation. But as long as we treat it, that's the most important thing. So these are all the different causes, and it's not an exhaustive list. Common clinical presentation. So again, this does not apply to everybody. Just want to put that out there, but this is more often than not, based on all the research that we've done, this is typically what people present with, okay? Usually they have a dull or like a sharp pain and over their buttock area. You can kind of see this gentleman here in the picture, this animated picture. He's kind of reaching back with his right hand, and it's kind of touching that top red dot. We're going to talk about that. It's actually a certain physical exam sign that I kind of do called the Thornton finger. We'll talk about that briefly. But we're typically looking at pain at any of those 4 spots over there. Typically, it tends to be stiff in the morning because you've been putting pressure on it all night when you've been lying down or if you've been sitting for a long time. It can have a very varied presentation. So remember we talked about when the sacrum and the ilium kind of join each other, how weird that kind of joint is. That's why it has all these kinds of different symptoms, right? You can have pain that goes down the back of the leg, and that can look like sciatica. We talked about that. But you can also have pain that goes into the groin, right? When you have pain going to the groin, the first thing I think about is you have like intra-articular hip pain. You can have pain that kind of stays in the butt. Sometimes you can have pain that goes up the back. And so it's a very varied presentation. It tends to be worse when you sit for a long time, when you stand up from a sitting position. You see that very commonly. Anytime you're going up and down the stairs, your SI joints are really active when you're doing those things, right? When you're managing different terrain, for example, when you're hiking. What tends to help when you're lying down, when you're resting, when you're wearing that SI belt? The SI belt, what it does, the main job, is that really prevents that excessive motion that you get when you get like your ligaments to be a little bit more relaxed. So those are things that tend to help, along with obviously medications, injections, and all that. So I want to include this slide because I kind of wanted to take you guys behind the scenes, right? You come up to the office, I don't know, the way we do it here at Desert Orthopedic Center, you talk to the nurse, you kind of give a basic history, right? What the pain is, what makes it better, what makes it worse. But for me, when I come out, right, you can imagine me as like the android in my glasses. I'm looking at you and I'm breaking down all these different things. It's not like that, I promise. But I am obviously, the clinic visit really starts before I even walk into the room. Because I look at your chart, right? I look at who's talking to me, right? How old is this person? What other conditions do they have, right? What surgeries have they had in the spine or the hip, right? We didn't talk about hip surgery, but hip surgery also can affect the SI joint pain. It's all in the same neighborhood, right? How did this start, right? We talked about those factors, like, was this a trauma? Was this a fall? Did this just kind of gradually come about? Like it started 10 years ago, but it was just here and there. It kind of went away with ibuprofen. But then recently it's just been getting really, really, really bad. Oh, and I went on like a 10-mile hike the other day. Maybe that has something to do with it. Where is this pain going? So we talked about the radiation, right? I'm very big on that. That's why, maybe my patients can tell you this, but I ask very specific questions about that. Not just like it's going down the leg or it's going over the butt, like where exactly is it going? Because I'm really trying to rule out other things. I'm really trying to get a better idea where that pain is. I'm always kind of ruling against a pinched nerve, which is what radiculopathy is, which is what sciatica is, not to confuse you. I'm ruling against like facet arthritis. I'm ruling against degenerative disc disease. This is pain when you kind of lose your disc height. I'm ruling against myofascial pain. This is sort of the pain just from overuse of your muscles, and the fascia, which is sort of like you could think of it like a connective tissue layer that separates your muscles. I'm ruling against a fracture, cancer. The latter two are very rare, but we do see that from time to time. But it's all a varied presentation, and there's a lot of overlap. And so that's what makes this diagnosis hard, but I think it's what makes a lot of diagnosis in, spine, the realm of spine medicine, really hard. Diagnosis, it's a clinical diagnosis, means I don't need a specific imaging finding to say that you have SI joint pain. I don't need a specific lab value, a specific lab to tell me that. It's a combination of your history, the physical exam, which we're going to talk about in a minute. And, we do imaging, but it's really more so to rule out the other things, right? When you have pain going down the back of your leg, and I think it's SI joint pain, I think it's sciatica, I don't know, but I see a disc herniation on your MRI and it's impinging that S1 nerve, then I'm probably going to think it's more of a S1 radiculopathy than a SI joint pain, right? And I obviously have the physical exam sign to help me out as well. This is an X-ray, just an AP anterior posterior, just kind of look forward. You can see, I'm going to go over with my mouse here. You kind of see these are your hip joints here. This is your pelvis right here. You don't want me to go in here. This is like your bladder somewhere around here. But you can see the signal sort of light up here, right? That's what we say is arthritis. It's just kind of like that increased bone formation. You can still kind of see a little lucent line, right? That's pretty good. That means it's not as arthritic as some other people. Some people, you just see kind of like a dark line, right? That means SI, the sacroiliac joints kind of fused. And we do see that, especially in our older population, but sometimes in people who've had a laborious job that have done a lot of construction, you may see that in them as well. So that's just a typical X-ray image. It matters, but like I said, it doesn't matter in the long term if I don't feel like your symptoms match up to it. Again, talk about the MRI. The CT scan, sometimes we order that when we can't do an MRI. It's really good for looking at specific like bony abnormalities. So if you have a potential like compression fracture, it's good to look at that if I can't get an MRI. If you've had a fusion and the surgeon wants to see that your fusion is actually taking place, it can better delineate that. So a CT scan from your perspective, you can kind of think of it as more nuanced or a more comprehensive X-ray scan. It's a different type of scan, but it's better to look at those little bone changes. The gold standard, we talked about how hard this is to make a diagnosis of. So what would be sort of the gold standard for making this diagnosis? And I say this, and I think the reaction I get from people tends to be varied, but sometimes in pain medicine, the best way to diagnose something is to treat it and to see if it works. Now, we don't do it willy-nilly, right? We can't just, you get, stem cell, you get steroid, we don't do that, I promise. But sometimes if I'm kind of on the fence and I don't know exactly what's the primary pain generator, if it really is SI joint, if it's more of your, lower lumbar facet arthritis, I would inject you with a numbing medication. What the numbing medication does is that wherever it goes, it just turns everything off, right? Now, a lot of you guys had numbing medication before when you go to the dentist, right? I think most of you probably been to the dentist. They give you the numbing cream, whether it's an injection or some kind of a cream they apply. They do that because when they do any kind of like cleaning of your teeth, it tends to be hurtful. And so this is the same kind of concept. We put our needle all the way down into your SI joint. We do that through like X-ray guidance, and we just put a numbing medication in, right? And that medication is going to wear off, right? Like all medications do. And then we have you go home and then just kind of keep a pain diary or just keep track of how you're doing. Did you feel different in that 6 hours, right? We're gonna turn you into this. We're gonna give your SI joint a break. We're just gonna turn all that inflammation off just for a little bit. And if you got significant relief, that means that it was a successful injection and it confirms the diagnosis of sacroiliac joint pain. That's the gold standard. That's really the best thing we have so far. Now, maybe in the future, there'll be some kind of study that comes out, some kind of imaging modality that will just pinpoint SI joint pain with 100% sensitivity or specificity, meaning like if it shows SI joint pain, you have it, but I doubt I'll see that in my lifetime. But if it, maybe in the future we'll be able to update that. But as for now, that's still sort of the gold standard. So like I said, clinical diagnosis, combination of history, physical exam, and then the diagnostic injection. Need greater than 3 positive maneuvers. So I think we're going to talk about that. SI joint, one of the reasons why it's a hard, diagnosis to make, they've come up with these physical exam signs. Your doctors may or may not have done any combination of these, but these physical exam signs, and we're going to talk about a few of them in a minute, these are what we do to really trigger your SI joint pain, I always, I need to make sure I ask someone, that they don't hate me before I do an exam because I'm going to cause them pain, unfortunately, but I have to because I need to figure out what I'm doing is going to cause you pain. So a lot of our physical exams are not as pleasant as maybe a cardiologist like listening to your heart. But unfortunately, that's the realm that we're in. We kind of have to not hurt you, but we have to hopefully try to hurt you in the right way to figure out the pain is coming from that particular spot. On the far left, on the top part, you see the foreign finger sign, right? So I kind of pointed that earlier. It's basically right next to a part of your ilium called the PSIS. And all I do is I take my thumb. You can think of it almost like, it varies person to person, but sort of where your crease starts, in your butt crease, about like an inch lateral to that. If I just press down there and you start getting like pain, I'm not talking about pain like you get pain there and I pinch you on the top of your back, it's the same kind of pain. Pain as in you almost like lose position, Sometimes I'll press someone there and their legs will almost give out because of how tender that area is. And so that's one of the exams that I like to use. Just give me 1 second, I'm just gonna take a sip of water. So Patrick's test stands for Faber, which is flexion, abduction, external rotation, is basically exactly what it says. So we have you lying on the table, and you can think of it as like making a figure 4 with your leg. So we have you flex your hip forward, then we abduct. Abduct means goes outside, and then we kind of externally rotate your hip. And when we do that, we trigger that sacroiliac joint pain. And you start feeling the pain kind of where that foreign finger is. And that's a positive sign. Sometimes The way we kind of learn about it in medical school and training is you get pain on the other side of your SI joint, but that's still positive for the SI joint on the other side. So, for example, if I do that and he's doing the right side, you might get pain over your left SI joint, but that's still a positive sign for right SI joint pain. Compression test is sort of a test when you're lying, it's on the bottom right here. You're lying sideways, right? And so your SIs are kind of lined up next to each other, and I just kind of press down on it. And so we compress that SI joint, right? It's already angry, and we're going to make it a little bit angrier. And then on the top right, the distraction test is basically like we're talking to the patient, we come in, we kind of crisscross our arms, and then we kind of bear down. It's almost like a frontline compression test. But it's more there to like kind of distract your iliac crest. And you can see that can also form pain. And then finally, you have your Gainsland's test. This is a weird exam. I don't know if you can really see it that good on the, yeah, you can see it on the table. So what we do is, let's say we think you have left SI joint pain. We get you kind of scoot towards the end of the table. And if we think it's left, then we have you scoot towards the left of the table. And then we have you kind of just dangling your leg off, right? And then you're going to flex the right knee towards your chest, and you're going to hug it really tight. And then what the examiner, like myself, would do is we're just going to press down really hard on your leg, and we're going to really try to shear that SI joint. We're just trying to create that shear force. And then you get pain, and that's considered a positive. So a lot of insurance companies, when they approve this injection, including, Medicare, they want us to have at least 3 positive physical exam signs. This is not an exhaustive list. The Fadir test also counts. So Fadir test is actually very similar. I don't have a picture of it, but it's basically when you flex your hip and you kind of do what the Faber sign shows in the top middle. But instead of the figure 4 going that way, you just kind of turn it and you internally rotate. That's more of a test for your hip, but sometimes when we do that, you can get pain localized to your right lower buttock where your SI joint is. So I know I spoke a lot of medical jargon there. I don't know how much you were able to take away, but now the doctor's just not there to torture you. He is trying to do something. But maybe he is trying to torture. I don't know. But at least there's some understanding of it. I just want to make sure I didn't miss anything here. And yeah, I think I got everything. But there's different physical exam signs too. This is not like an exhaustive list. But because it's such a hard diagnosis to make, doctors will kind of run through the gamut here. And again, if you're as a doctor, like I can't really trigger this, but I really think it is, then you have a discussion with the patient, and then that's when you kind of utilize that diagnostic injection to make sure you have the right spot, right diagnosis. The treatment, initial for any kind of treatment, I always get people coming in, wanting an injection. Some people come in wanting to get surgery right away. Anytime you have any kind of diagnosis, right, the standard of care for most things is, obviously conservative management, right, which is a combination of rehabilitation, therapy, bracing, and then medications. Ideally, you just send people to PT, right, but if people are coming to you for the first time, they've been dealing with this pain for months, sometimes years. I try to set them up on a multimodal regimen, right, and there's different tiers we go to. Even though I'm an interventional spine doctor and I love doing injections, that's why I decided to join this field. I'm excited about all the different procedures that we can offer, especially now. It's really one of those golden ages. If I don't have to inject you, if I don't have to put you under the knife to do any kind of surgery, then that's the last thing I want. And I think even the best surgeon would hopefully hold that, right? I mean, you don't want to have that mentality that everything looks like if you have a hammer, everything looks like a nail, right? I don't view medicine like that, right? The least I can do, and I can improve your pain, that's what I'm going to do. And so anytime I talk to patients, I always kind of walk them through every step, right? Because injections are harmful, right? They have their complications, and sometimes we don't think about that. Every time I go over the process of an injection, I go through all the risks, right? What are the major risks? Infection, damage to the spinal cord, and I see people's faces, and I just see their faces like cringe and change, and I'm like, I get it. I mean, the chances are very low, but these are part of the risks, right? I mean, we go on roller coasters, that could end up really badly, right? But we still we do it. Now that's different. That's for fun. This is not for fun, but everything has its risks. And so physical therapy is the first step. What we do is, aiming there to kind of stabilize the pelvis, really stabilize your alignment. A lot of people, I know when I talk about physical therapy based on their prior experiences or their friends' prior experiences, they're kind of, hesitant to go to physical therapy. And one thing I always tell them is we have great physical therapists here at Eisenhower, Rancho Mirage, Palm Springs, La Quinta. But I always tell them, like, listen, I know you're nervous, you don't want to go, but go for the initial evaluation. Go for a couple of weeks, right? Because when you go to a physical therapist, the first thing they'll do in your first visit, like I'm doing here, is they're going to evaluate you, right? They're going to check your whole alignment. And then they're going to provide a guided home exercise program that's tailored to your needs, right? Now, it still doesn't work for some people, right? But it's, I think, really important for a lot of people to just kind of get checked out. Because you don't just have the SI joint pain, right? You probably have other stuff going on. And so that's why I think it's very important to go to a physical therapist. I don't know if they would appreciate this metaphor, but I think they're kind of like the personal trainer for you when you're in pain, right? They're that guide for you to kind of hopefully restore your pain to a less painful and more functional quality of life. Some people want to go to their personal trainer, and I think personal trainers are great. I'm sure some of you have had experience with them. But when you're in pain and you're working with an actual personal trainer, that's not really physical therapy, right? That's not what they're trained to do. They're trained to push you and to make you more fit. And sometimes when you're in pain, trying to become more fit may kind of work against that, right? You shouldn't be lifting heavy things or doing 100 crunchies in 45 seconds. That's probably not the best thing to do when you're in pain. So I just kind of want to give you that little spiel about physical therapy because I do think it's very important. And if that's the only thing I could, prescribe for people and I can't do any injections or medications, I'd be more than happy for that. But sometimes we do need other things to help out. Therapeutic manipulation, chiropractic adjustments is another option. Chiropractic care is definitely something that a lot of patients like. I am not really in the setting to discuss more about that. I think it's something that, benefits a lot of people. It's something that I'm not really, honed in my training. And so I always, tell people that if they're interested, that I'm more than happy to obviously, talk about different options here. But in my training, I really work more with physical therapy. So it is an option. And when you come in and you've done chiropractic care for your back pain or your neck pain or whatever, we do consider that as part of your rehabilitation. So I can't really give you more information than that. That is something that you can kind of consider as part of your treatment. Bracing, I have a picture here of an SI belt. It looks a little bit more comfortable than a back brace, right, than a lumbosacral orset. Definitely more than a TLSO. That's what we get for people that have like compression fractures. So this is a belt. I love this because this is one of the only things we can probably do for pregnant ladies, right? Whenever someone's pregnant, we shouldn't be giving them too many medications, right? They can't really get an injection because then they'd be exposed to the radiation. We don't want the fetus to be exposed to the radiation. So sometimes the belt is something that's helped a lot of people. And so when I do have that diagnosis and it matches clinically to their symptoms, I've seen the SI belt help a lot. It is not to take the function of your sacroiliac joint, but it's just to kind of keep things tight and to give those ligaments and those muscles a break. Now, the caution against wearing an SI belt is if you wear it for too long, then those ligaments and those muscles, if they had a personality, are going to be like, well, I guess this person doesn't really need us anymore, and they're going to wither away, and we don't want that. And so when you're in pain and you can't do much activities without kind of triggering all that inflammation and causing pain, the SI belt's a great way to go. But I don't really have people wear it for more than an hour, max hour and a half to 2 hours a day, usually at the time that their pain is sort of maximal. For some people, that's at the end of the day. Usually it's the end of the day because you've done so much work. Sometimes it's in the beginning of the day. And then finally, activity modification. We do have a few snowbirds here. I know I've talked to a few. There might be more on the Zoom. I know you come to Palm Springs to play golf, right, and to enjoy and to vacation. So that's like the last thing someone wants to hear, right? Like, what? You don't want me to play golf? I just booked 9 rounds this weekend. What are you talking about? But, one of the things when you're in pain is that one thing I didn't mention here is your own body. Your own body is treating you as well, right? Anytime you cut yourself, right? You should probably get a Band-Aid or you're gonna potentially bleed out. But if you don't apply any Band-Aid, eventually your body's gonna plug up that hole, right? So your body is kind of fixing this inflammation. Sometimes it can't do it to the level that you need. And so time is also another modality of treatment that works for people. So I definitely encourage you to focus on that. Okay, so please, like, I know you want to come here and you want to play golf and you want to go on these hikes and all that, but when you're in pain, that's a sign that whatever you're doing, hiking 9 miles, right? Like, it means you need to just go down. And so I always say, kind of tamper down a little bit, compromise with yourself, and then hopefully once you're able to kind of get this pain a little bit in a better place for you, you can kind of resume your activities, lifting techniques, and that's why I think PT, kind of bringing back to them, that's why they're very important too, because they can really kind of help, manage that to make sure your alignment is correctly, I think I was lifting for a couple of years and then I went to a therapist because I had a knee surgery and I realized I was doing so many things wrong. And so he was able to kind of better help my posture as well. So that's why PT is very important. So activity modification, we don't want to do it, but you got to do it. And patience. But you can't bill for patience when it comes to insurances. So not many people have patience for patients. All right. Finally, medications. Topical ointments are always a good idea. Lidocaine patches, you can kind of get that over the counter. Ice and heat packs, alternating that are very important. They work in different ways, but they're also good to apply. Voltaren gel, the only thing I'm going to say in the parentheses is basically topical ibuprofen. So some of you guys that have a kidney disease or you have heart issues, right? Your doctor, your PCP is probably telling you, hey, you should probably limit the use of like ibuprofen or Celebrex or meloxicam. So Voltaren gel, when you apply something like topically, it does get absorbed in your system, but it's not as absorbed as if you were to take it orally, like a pill, or if you were to inject it into your veins, right? That's more of that kind of goes throughout your system. So just be aware of that. So even though you're applying it on your knees, and it's the only thing that works for like your arthritis, just know that if you have kidney issues or anything like that, you are intaking non-steroidal anti-inflammatory, which is the category that the ibuprofen is in. So just something to be mindful of. And then when it comes to the oral, medications, obviously the non-steroidals, ibuprofen, Motrin, meloxicam, Advil. Advil is naproxen, and then Tylenol. Tylenol tends to be the safest medication that we can utilize for people. The only caveat for not using Tylenol is if you were to have any like liver issues. But the safe dose that you can take of Tylenol over a day is less than 3 grams or less than 3,000 milligrams, right? So a lot of their Tylenol tablets, I think, come in milligrams. So just make sure that you're taking less than 3 grams. And then for anybody that has any like liver issues or anything like that, I think the recommendation is less than 2 grams. But they're always updating it. I think earlier, like when I was in med school or early in residency, it was less than 4 grams. But recently they've updated to less than 3 grams. So those are over the counter. You can get everything really up to the muscle relaxants over the counter. Then we come to the muscle relaxants. We have like the 3 major ones: baclofen, cyclobenzaprine, tizanidine. There was one, Soma or Caprisol. It's really not prescribed anymore. It has some like opioid-like addictive properties, so it's kind of gone out of favor. And then the new one is Journavx. I know I've prescribed it a couple times. It is very, very expensive. So it's a medication that I think does work. It's only given for 14 days, but it's something that unfortunately many patients just cannot afford it. And if someone has the means to afford it, they'd rather do some kind of a PRP or stem cell injection than take a oral medication. So it's something that I don't really have a litany of patients that are on it, so I can't really tell you much about it. Baclofen is a great medication. It is a muscle relaxant. All muscle relaxants work differently, but they do have their share of side effects. All medications have side effects, especially the medications that a doctor has to prescribe. There's no way to get around that. That's like wanting to eat chocolate cake and not like gain any weight. It's just impossible, right? Baclofen is something we have to be careful for when people have like kidney issues, just because it does get eliminated by the kidneys. Your kidneys are like your elimination system. So imagine you don't take your trash out, eventually your house is gonna, smell really badly. So the baclofen will stay around in your house, in your system. And that means a dose like 5 milligrams a day, which is a very baby dose, could be more like 50 milligrams for you if your kidneys aren't working well. All these medications, baclofen, cyclobenzaprine, tizanidine, they all cause sedation and drowsiness as a side effect. So that is something that I probably tell people that's more really of an expectation. Many patients have that side effect, not everybody, but many of them do. But the last thing I want is for you to take Flexeril as like a sleep aid, okay? It's a pain medication. So if it's only helping you for sleep, then we probably shouldn't be taking it. Cyclobenzaprine and tizanidine tend to be very similar in the side effects they cause, but each of these medications kind of work differently in your system. You still cannot take more than one. So if you look at your medication list, if you're on multiple of these, make sure you're talking with your doctor because you should only be on one of them, okay? Opioids, very rare, usually, obviously avoid if possible. They're really only given in the sense that someone's had a history of like surgery in the back, or they've been on opioids for some other issues, and then they have the SI joint. So we typically, just for an SI joint pain, typically try to avoid opioids. But, this is sort of this medication sort of ladder that we try to follow. And so they are still given from time to time, but it is very rare. Usually when injections or surgeries just don't work is when we probably think about starting opioids. So interventions, right? My favorite part, the non-surgical treatments. Intra-articular, this is where we put a needle into the joint. California does require that we do a diagnostic injection, so it's part of this treatment. And so you have to come in, you have to get the numbing medication, you have to go home for a day, see how you feel, and then we follow it up with a steroid injection. Regenerative therapies, again, they're not covered by insurance. This is PR, platelet-rich plasma, stem cells, and dextrose as well. And then one thing, what was that? Thank you. Yeah. I mean, they're working on it. There's different reasons why. Probably can't get into it, or we'll talk for another couple hours. The last one is thermal radiofrequency ablation. Some of you guys might be aware of this. This is what we do for like arthritis in your lower back when we ablate the medial branch. Well, some of the nerves and the posterior aspect of the SI joint, we used to have a technique. We still do this procedure. It's just not covered by insurance. But what we do is we kind of block the nerves that go to the SI joint. The thing about the SI joint, as opposed to the facet joints, is that the facet joints are only posterior. Your sacroiliac joint is posterior and it's anterior. So insurance is realized that basically you're only ablating the posterior part of the joint, not the anterior. So that's one of the reasons why it doesn't work anymore. Who's Charles Hart? He's okay. Writing on my PowerPoint. All right. And I have a picture showing that on radiofrequency ablation right here. All right, so it's okay. This is a nice slide here. So on the left, when you guys are lying face down, about to get SI joint, what I do is I open up the SI joint. And so if I just take an X-ray, I won't be able to see a nice lucent line like that, because your X-ray just looks at you straight front, and it can't really take angles. But with the C-arm, which is basically an X-ray, like a typical type of X-ray, what I do is I angle it really contralaterally. So if I'm doing a left SI joint there, I kind of oblique it 10 degrees to the right. So it's kind of like a, little curve, AP, but a little tilted to the other side. And that opens up the joint. And then the SI joint, top part of it's kind of fused, the bottom part's more open. And so we put our needle and we kind of target it, going there. So remember, you're looking at the needle from the top down. So your needle isn't exactly that size. You're looking at it it's a 2D projection of a 3D procedure, right? So we try to go into that joint, and then we put the contrast in that you can see on the right. Again, sorry, it's getting a little obscured by the blue writing there. But you can see the contrast is in the joint. And that tells us that we're in the right spot. And then once I have that, I save that image to show off later to my friends. Or no, I'm just kidding. To show off to patients afterward. And then we follow it up with a steroid injection after. So The nice thing about the fluoroscopy is that we have the contrast to tell us where everything is, and then we follow it up with the steroid injection. This is the radiofrequency ablation. So you can see we have 4 needles there. They're basically like in the parking lot, right, of the SI joint, right? It's just right outside there. And it's there, and it basically, we put our probes there. It's connected to a wire that's going to kind of burn, and we burn it for 90 seconds. And so we're burning the lateral branches, that's what we say, that's going to the SI joint. So this is something that still we offer here at Eisenhower Medical Center. It's just not covered by insurance. So it is unfortunately a cash pay procedure. So I think you may find some Medicare around the country that can still cover it, but it's very hard to get covered. So unfortunately, it's not something we do. It's been going on for several years. You've had 2 of them? Oh, okay. SI joint or lower lumbar facet? Okay, that's interesting. It was here in California? Okay. Okay. All right. Well, I'll talk to her. But as far as I'm concerned, as far as I know, it's not covered right now. So that's something we provide to the patients so they can see. And this is just a slide of like the regenerative therapy. So again, it's an SI joint injection. Usually we do it with ultrasound because we do want to inject into your ligaments and your tendons, and an ultrasound probe is a little better for that. And then this is just we take a picture of your blood and then we kind of spin it down in a centrifuge. And so the top part's your plasma. We kind of separate it from the red blood cells, and that's what we kind of inject into your system. So you're providing your own medication, which is a kind of a cool thing, but still pay a lot of money for it. Then there's stem cells. That's a little different. Dextrose. Those are all regenerative therapies. Major risk. I think I covered this before, but again, infection's the biggest thing. So one thing, we can't really catch, but you can't really be on an active antimicrobial. Like if you had a UTI like a couple days before, you probably don't want a steroid, or you don't want someone putting a needle all the way down, really on the other side of your bladder. So that's something that it's a big no-no. I like at least 2 weeks before and after major sort of procedures. For any antibiotics, I kind of wait 4 to 6 weeks. This is an elective procedure at the end of the day. I know it doesn't feel elective, but we want to take the most caution that we can. Excessive bleeding is possible, but this is a very low risk injection. That's really more so for the epidural injections that we do. And then finally, you are close to the sacral nerves that come out, so you can still get motor paralysis, sensory issues. So this is sort of the spiel that you hear the pain doctor talk about. And that's something that we kind of disclose. Again, not an exhaustive list. Those are the major things that we talk about before we do an injection. Finally, we do offer surgical fusions. There's 2 types. There's the transiliac and the intra-articular. So the transiliac is kind of where that blue line is kind of crossing. You can see the surgeon will come from the side, and he'll basically cut through the ilium, cut through the sacrum, and then kind of bind it together. And that reduces that excessive motion that happens when your SI joint's inflamed. And then posteriorly, you can kind of see, we kind of go into the joint, and then we just kind of put a little screw there. And I have a picture for each one on the fluoroscopy. But this is a procedure that's kind of done outpatient same day. You're given a short course of opioids, really not to take more than a week. You're given antibiotics as well, just given that this is a procedure that goes into your SI joint. But it's the same day. You're able to go home the same day, and you don't need to be admitted to the hospital. So it's really nice. This used to be done with the whole neurosurgery and spine surgeons. They used to kind of open you up, and you probably were admitted to the hospital. But nowadays, interventional pain doctors can do this procedure, and it's more minimally invasive, better recovery time, et cetera. So this is sort of the last step of the pillar when it comes to your treatment options. This is your posterior. This is how the screw looks like. Again, it's not that size, right? Because we're only looking at it from one dimension. But this is kind of like a posterior SI fusion. And then the lateral SI fusion, you can see these 2 screws. Most doctors can typically do these procedures under an hour once they get pretty good at it. But yeah, that's your posterior and lateral. So I do treat other things than SI joint pain. This is just a few of the things that I kind of treat and can see you for. So more than happy to talk about this if you have questions about it. Those are my references, and then just open it up to any questions you have. I think we're almost at the 1 hour.
All right. Thank you, doctor. We'll do in the room first, and then we'll go on some Zoom. The woman in the front row. Yes.
Yes.
If we could say the question again so the Zoom audience will hear it, that would be great.
I think the lady's question here, or woman's question, was regarding stimulator trial leads and putting an implant in. Yeah, so typically that's not done for SI joint pain. That's done for a variety of conditions, but the most common reason for doing that procedure is like failed back surgery syndrome, which essentially just means people that have pain after they've had a fusion of their spine. There's other things like chronic complex regional pain syndrome, chronic pain, like you've had fusion, you've had all kinds of injections, but your pain just won't go away. But for an SI joint pain specifically, we typically don't do that procedure. It's very rarely done. You might be able to find a pain doctor that does it, but it's not one of those. He did it for SI joint pain? Okay. He might have be doing it under like you having like chronic pain, but it's not one of those treatments. If you look at like SI joint, any like literature on that, it's just not one of the procedures that's done. Yeah, but it's more so probably for chronic pain. Like I don't know if you've seen him for like other things like, you know, just SI joint. Okay, yeah, that's rare. It's not typically done for that. I wouldn't do it for that, but I'm sure your pain doctor's seeing you, and so he'll probably manage you that way.
Great. We'll take the question in the back of the room, the gentleman here in the blue shirt. Yes.
You get some medial in the upper back, but I think if I start seeing it go more medial, it's not. You can, to answer your question, you certainly can, but you start having like here, you have your ischial bursa here, so it's tend to be more protected. So if you have pain here, I'm not exactly thinking of your SI, but this is just a picture. It does not cover the whole distribution of the SI joint pain, but you can have pain there. Yeah. Yeah, it can kind of go up there. But remember, SI joint pain is not like it's this or that. Sometimes it's in addition to. And so sometimes I can target an SI joint pain. You may come back with more pain, but I'll tell the patient, I'll look at the chart. I'm like, well, you don't have pain in the same distribution that you had before. And so sometimes that means that whatever the secondary or tertiary pain generator was kind of replaces the first one. So you can, yeah, it can go around to your hip. That's true. Yeah. I just put the back of the picture, but there is a front part too, so it can go into your hip. That's true.
Let's go to the woman over here on the left. Yes.
Yeah, that's a great question.
If we can repeat the question, that'd be great.
Yeah, of course. Yeah, so thank you for reminding me. So the question was that the woman here looked at her picture at the SI joint, and she had pain along right here, but then where the needle was placed, which I'm assuming is somewhere here, it wasn't over the area of the pain. That's a great question. And remember, we're not putting where the area of the pain is. The only injection I do that for is like a trigger point where I just go into the area that you have like a muscle, like a trigger point. But remember, a lot of where we do the injection, it's called referred pain. And so this is the sciatic nerve is like here, but you see how some people have pain going all the way down here? They may have pain mostly here, but my needle's going to be all the way up here somewhere, right? So we always go where the pain's referred. And so yeah, right. So on the differential, right? If it didn't work, then I assume that it's probably more of like your lumbar facet arthritis that's causing the pain, or myofascial, which is just kind of over that area. But those would be on the other two things that you can kind of consider. Yeah. Uh, I don't think so. You guys are asking great questions, but there's some questions I have to be very political about.
A question, what do we think of like I hear all the time about a like sciatica, like a TENS unit, putting the little electric pads on the back, for those kind of things. Does that help? Does it work?
It does work for some people. That it goes to this thing we call the gate control theory. Whenever you guys, let's say you scratch yourself from like a nail, what's the first thing you're gonna do before that? That's a good thing. Definitely disinfect. But the first thing you're going to do is with your, let's say you scratch, you're going to, with your hand, whichever's closest, you're going to rub on top of it, right? That's the action I'm doing right now for people looking at me. And what you're doing is you're activating these A beta fibers to kind of override that pain signal. You're kind of infusing your brain, right? Your brain is where your pain comes from ultimately. So you're telling the brain, hey, don't focus on that, focus on this. And so what a TENS unit and even a spinal cord stimulator that actually works similarly with this gate control theory. And it's just a theory, right? But what it does is that it stimulates the A beta fibers and it kind of overrides the pain. For some people, it does work, but with anything over time, like for example, for me, a coffeeholic, you're gonna get used to it and it's gonna have diminishing returns over time. So, but it does work for some people that are in acute pain.
All right. More questions in the room? Yes, ma'am. Go ahead.
The question was, can hormone replacement stretch out your sacroiliac ligaments? That's a great question. One thing I do know is that when you're pregnant, obviously you have hormonal changes. And so you can, the reason why a lot of pregnant women do get SI joint pain is your ligaments loosen. So hormones can cause that. So hormone replacement, if it's done in the right way, I don't see why it would, because you're replacing it. You're not going super, like you're not going over the, that's probably a better question for an endocrinologist. I'm not really sure if we've ever like looked into that, but that's a good thought. Yeah, go ahead. So another question was, can tearing, can you expand on that? Yeah. So that's a great question. So she was asking, I think the lady said we have a tearing of a ligament or a muscle. And so, yeah, that can be a cause of pain. We say SI joint. I think the better term would be sacroiliac dysfunction because it doesn't just involve the arthritic changes in your joint. It can also involve those ligaments loosening or getting a tear in them. Yes, so that can be a component of your pain. Really not something I think you'd operate on unless it was a really bad tear and it was causing instability to your pelvis. Yeah, yeah. I think I don't know your history, but I think I would imagine it's probably tied to like your history with your lower lumbar and your SI. Yeah. Yes, sir. Yeah, steroids do carry their own kind of risk profile. I didn't really expand on this here. One is like it does increase like your blood sugar, and so some people that take like oral prednisone for a long time can get like weight gain and all that, increased risk of metabolic syndrome. The risks are obviously tempered with when you're just doing localized injections, but you do get absorption over time. So that's one risk just for steroids in general. Um, Something you don't want to do too often when you're young because it does lead to the wear. It causes cartilage degeneration. And so if I do steroids, it is limited to like a couple a year. Probably over time, we want to be careful because if you're getting SI joint pain, you shouldn't, as a 26-year-old, for example, you shouldn't be getting 3 SI joint pain injections per year for the rest of your life. But there are some people that have like ankylosing spondylitis, which is an autoimmune disease, and they have such back pain that they can't move. And so something we always have to consider is that, the pros and benefits, right? I mean, yes, we are doing damage to your cartilage, in the long term, but if we don't do this, then what is your quality of life? Right? So that's a existential question that we kind of have to ask ourselves with these injections. And that's why the regenerative therapies, I think, have taken such importance because you don't have that risk with them. You have other risks for sure, but the cartilage degeneration is a big thing with the repeated steroid injections. We don't have like long-term data on it. They really are kind of different. I think that the lateral approach is, to me, it's a more invasive surgery because they're going to go through two bones, but really kind of, isolate it and kind of join it. When you go into a part of the joint and you put like a little screw in, the joint is so big, you really need to like put the joint together. That's a common area of debate. That's probably outside the scope of this lecture, but right now there's good data for 1 to 5 years. The problem is I didn't talk about the different companies like Pain Tech and all of them, even with spinal cord stimulators, right? All the research that's out there is going to be very positive. but it's not like, we need more data because anytime one of these SI joint companies publishes studies, it's kind of a coincidence. It's always amazing, like 80% relief. So, but there are some independent studies, and so it's still kind of new, especially in the pain medicine realm, because this used to be done exclusively by surgeons. But I do think it's something that's warranted if all other treatments have failed. But right now, they have good data for up to 5 years, but still not enough data, if you ask me. Yeah, I mean, I think that we do give a home exercise program. We kind of take it from AOAOS, which is one of like our orthopedic societies. And it's very good. I mean, the goal for, SI joint is first to kind of make sure that you're stretching your pelvic muscles, that they're not stiff, and to make sure your abdominal muscles are strong. The only thing that worries me, and I give the home exercise program so people will start on it, but I don't want to give them, and then they do these exercises when they're not really ready to, because it's just a standard thing, right? It's not really tailored to what they have. When you go to a therapist, they're tailoring their home exercise program based on how you did in that first hour, right? If you're barely able to get out of the chair, they're not going to have you do like 20 jumping jacks, right? So we want to make sure that we tailor to it. But the goal of these exercises is to kind of strengthen your core. But before we strengthen, we do need to work on your flexibility first. Are you talking about SI fusion? That I don't know. I personally have not done any SI fusion cases, but if they're in so much pain at the time that doing exercises has probably not been a successful thing for them, or they wouldn't be a surgical candidate. So no, I don't think so. Yeah, I think you're talking about prehab, which is one of those things that a lot of like a lot of surgeons start doing. But I don't believe that's a thing for SI fusion, but I don't know the answer to that. Yeah.
All right. Well, I think we're at time, a little over. Thank you all for being patient. And thank you, Doctor, for being here. And just as a reminder, this was recorded, this will be edited, and I'll be sending it out to everyone who registered within the next 2 weeks. So it'll be in your email. You can find all of our previous lectures, everything else on eisenhowerhealth.org. You can also find it on our YouTube channel on Eisenhower Health. Thank you all for being here, and we'll see you soon.
Thank you so much.